Hello, everyone. My name is Thomas Nickwitz. I'm a second year grad student in the athletic training program. So today I'll be presenting on a pretty interesting case. It involves a female collegiate basketball player who suffered a syndesmotic ankle sprain. So just an introduction or background on the patient. It is a 19-year-old female freshman collegiate basketball player. She is a forward at She does have a history of lateral ankle sprains and plantar fasciitis. As far as the lateral ankle sprains, these were all mostly grade 1, so not too severe, but she does have some ankle instability issues as well as the plantar fasciitis. She does have a history of chronic inflammation, so this is important to take into account later on. This patient tends to heal longer and have more swelling and inflammation for a longer amount of time. The patient does not have any foot orthotics or no supportive taping or bracing at the time that her injury occurred. So this injury occurred a few weeks before starting the fall semester. She just landed awkwardly while going out for a rebound. She was just shooting outside in her driveway, and she just landed awkwardly, heard an audible pop at the time of the injury, and she could not put any sort of weight on it soon afterwards. And she went to go get x-rays, but we'll dive into that later on. So just the purpose of this presentation is to really go in depth and explore the whole examination to recovery process and eventually return to play for this athlete, and being able to see the whole plan of care involved, especially for a high ankle sprain, that most common name for this injury, but the syndesmotic ankle sprain in this case. And we're going to evaluate various treatment plans and really see the whole process of providing patient-centered care, especially for a patient like this that has chronic inflammation, as well as other factors such as the plantar fasciitis. So when we go into the whole eval process, so again, when the injury occurred, the athlete can put too much weight on the ankle, went to the emergency room, x-rays came back negative. But when we take a look at the picture, again, this is not an actual x-ray of the patient, but this is something we would see in an injury like this. So we see the syndesmotic widening here between the two images, between the fibula and the tibia. So the ligament involved here is the anterior inferior tibiofibular ligament involved in the high ankle sprains. So the injury occurred, like I said, a few weeks before the athlete came onto campus. So the whole eval process really didn't start until a few weeks after the initial injury. But upon arriving to campus, she had swelling and redness around the lateral malleolus on the outside of her ankle. And she had range of motion deficits in essentially all ankle movements: dorsiflexion, bringing the ankle up; inversion, bringing the ankle in; and eversion. Eversion and dorsiflexion, especially for the mechanism of injury for this kind of high ankle sprain, that's the most compensated position a individual's ankle can be, and it is a really common mechanism for this type of injury, for this ankle ligament to be damaged. So the most telltale sign, we think of the Kleigers. So that was positive. It's essentially trying to recreate the mechanism of the injury, bringing that ankle right up and some external rotation. So that was positive for the patient. The anterior drawer test was also positive, and that is the anterior talofibular ligament, which is also involved whenever we think of the classic, I rolled my ankle inversion sprain. Ankle is outwards, so the arch is facing in. Talar tilt as well, measuring the calcaneofibular ligament. That was also positive. So the patient really had discomfort all around during the whole exam process, range of motion deficits, the telltale high ankle sprain, Cligers, basically all the ligaments of her ankle really were bothering her, but especially that, dorsiflexion external rotation test for the high ankle sprain. So the athlete had a suspected syndesmotic ankle sprain, and over the course of the rehab, within a few weeks, she also developed Achilles tendonitis from just the whole strain of the injury in itself, and the whole rehab process. Really started to get some inflammation as there, which we had to deal with as well. But however, the overall prognosis was great. No fracture occurred, as we could see on an example of what a syndesmotic ankle sprain without a fracture would look. But the patient-centered care comes in. You have to really cater to the patient's needs and wants. For her, wanting to get back to basketball activities, but also focusing on her chronic inflammation and catering the whole rehab to the patient. So the whole plan of care initially, being able to manage pain, minimize any sort of swelling. She was on a boot and crutches for the first few weeks. Made it easier for her, actually. So when she came to campus, only had to go on the boot and crutches for another week or so before she was taken off. So it's really convenient for her, especially, not having to walk around with a boot and crutches around campus, getting to class, things like that. She was home for a majority of that whole initial phase. And again, for her, it was great because she knew some from her history of spraining her ankle. She knew some basic rehab movements she would usually do at the start of any sort of ankle sprain, which has helped her a lot in the long run. So we use a lot of cryotherapy, electrical stimulation. So cryotherapy, the game ready, being able to have compression and ice at the same time for her ankle. Electrical stimulation, sensory. We were able to, again, be able to control her swelling, pain management, anything like that. And initial muscle rehab focused on intrinsic muscles, such as just marble grabs with her foot, just ankle pumps, some light stability work. Again, using, support with the desk, a chair, anything like that. So over time, we were able to progress to more ankle range of motion exercises, more resistance bands with the TheraBand, going in all of the ranges of motion as tolerated, being able to progress to more weight-bearing activities, squats, progressing from holding on to a chair or the treatment table, standing on a leg, standing on one leg, starting with double leg, of course, and progressing to one leg. Active release therapy, like the picture shows, that was the turning point for the patient, actually. So after a while, she stopped progressing. She still, had the range of motion deficits. So again, this is also when the Achilles tendonitis started to start. So we had to, cater the rehab or try to think of it in another direction here. So as the picture shows, active release therapy. So we used a lacrosse ball. The picture doesn't show this, but I just, picture online, not the real patient, of course. Use a lacrosse ball right underneath her calf. And she also had a kettlebell that was on the top of her foot. So she was able to have that active release therapy on her calf as she's doing range of motion with the resistance of the kettlebell. So that really helped her a lot. That was a real turning point, especially with Achilles tendonitis. I feel like when we were able to address that, the whole rehab process really started to get better and better as the weeks went on. Athlete felt stronger, more confident in the ankle. Joint mobs as well, being able to get that last few degrees of motion back, especially for dorsiflexion, which is really difficult, and eversion for this type of rehab, especially. And we used instrument-assisted soft tissue massage, again, to address the Achilles tendonitis, being able to break up those fibers with any sort of tightness. Sounds counterintuitive, but pretty much starting that whole inflammation process again, getting those fibers to realign more linearly instead of clumped up together as we think of like a scab. But we're really able to try to align those fibers better, increase flexibility, and help with the overall range of motion. Towards the end of the rehab, we did more balance work, one on one leg, trying to balance on the trampoline. Proprioception work, really able to sense your body in space, being able to adjust to certain motions, like going on standing on one leg and then catching a ball in different sort of directions. Then progressing to more on the court activities, cutting, dribbling, backpedaling, setting screens, catch and shoot, things like that. So again, this part of the rehab is more exciting for an athlete, being able to do their, again, in this case, basketball activities on the court. So she was really excited when she was able to be back on the court and do basketball related exercises instead of, just ankle pumps, TheraBand resistance, step ups, things like that. So when we concluded, it was 12 weeks of recovery. The patient did develop Achilles tendonitis within 2 weeks of the treatment. However, the turning point of the treatment was the active release therapy. Like seen with the lacrosse ball, the patient really was able to help her with the Achilles tendonitis as well as increase range of motion in her ankle. Again, in conjunction with the joint moves. And the recovery was stalled a week or so before this was implemented, but the joint moves were done on the treatment table. The athlete goes on one knee and really tries to increase that dorsiflexion, starting to lean forward on that ankle. And we would progress to trying to use a cane too on the floor with a mat against one knee, trying to lean forward using the cane. So that really helped the patient be able to regain that full range of motion eventually. And she was able, as soon as she was recovered, she was able to return to practice fully conditioned and had a full contact 2 weeks, being able to get her conditioning back, adjusted to the whole practice environment. Unfortunately, there were no games due to COVID last semester, but she was able to go back to full activity. She still continued to do maintenance work on the ankle, such as we did the soft tissue assisted massage, being able to increase more range of motion. And again, she continued to do strengthening, balance. Now comes in to get her ankle tape before practice for more security. But again, important for this athlete, especially with her history of lateral ankle sprains and the plantar fasciitis, it's really important to manage all of that and prevent the athlete from any more future injuries. So this comes in the form of ankle or strengthening, balance, and just increased flexibility through stretching and other modalities that we were using throughout the course of the treatment, like heat, like a heat pack or thermal ultrasound. And that is it. Thank you very much.